Sorry. We put the patient on pin traction. You can see the pin scars. And the fracture is united. The patient happily went home. Now one should be careful not to commit a mistake like this, because first chance is the best chance. Or another case. This patient he is a doctor himself. He had a segmental fracture. K-nailing was done. The nail missed the proximal fragment. It was hammered, produced a fracture of the femoral condyle. He went to a second person who did a DHS without the compression screw. Then he went to the third doctor who did an interlocking nail. He missed the distal fragment. He came to me. I advised him a fourth surgery. He said, Namaste. To summarize, one should keep in mind that the first chance is the best chance. Do not be in a hurry to rush in for the second attempt. All failed cases do not need another implant. If nails fail, try the plates, or vice versa. Replacement arthroplasty should also be kept in mind. Thank you.
I think we now have the discussion. Let's take the questions from the floor. Please get up, say your name and author to whom you would like to ask a question. Question from the floor, please. Yeah, come there, come here. Yeah, Raza must sit here. You must see the ex-president. Come. Sit. Two chairs. Come, put chairs there. Yes, question to Dr. G.S. Kulkarni. Yes, doctor, come. Say your name and your question to him.
I am Dr. Pankaj Tandon from Kanpur. What is the role of using bone cement in osteoporotic unstable fractures? When we should use it? And secondly, the role of using locking plates in DHS.
Yeah. Now the synthesis has come out with the nail called as PFNA2. The PFNA1, they have made holes in it so that you can inject cement through the outer end. It goes around and fixes the better. But this is only to be done in osteoporotic bones. Yeah, you can fix it with...
with DHS in part 4 fractures, any role of putting in bone cement at the fracture site?
Yes.
To consolidate, to sort of help stability?
You can take a thin, some rod you can see, and then inject at the site in the head, and then put your screws.
All around at the fracture site where you sort of feel that, no, Chief, where you feel it's the whole thing is shattered, no bone cement there, sir.
Yeah. No, the fracture site, cement will cause non-union and also it will have problems. So no, not at the fracture site. You may fix in the head so that the fixation of the screw would be better.
So you are saying only wrapping the head with the doing part?
That can be done.
Not the shaft. Only wrapping
only in the head. The cement should be only in the head.
Dr. Kulkarni, the problem is that your cement setting and placing your screw is vital, because your theatre temperature is not standard. You will find that before you put the screw, your touch it is set. Second thing is that intramedullary cement, does it add to the bone? Thermal necrosis.
Can I answer this? See, the most important thing which we are forgetting in any kind of fracture fixation is the biology. One aspect is the biomechanics, but more important than the biomechanics is the biology which we are forgetting. So in all these situations, since the question has been asked, I would rather in osteoporotic bones, pulverize bone graft, and through the hole which you have already created, using your the hole for the barrel to put an extra bone graft into the hole which you have created for the thread, and putting in more bone graft at the site of the fracture also. And this I routinely do even for non-unions which I have. Putting in a lot of bone graft adds to the increase in the quantum of the bone which is there. And once you put in the threads, it makes it better and you have improved the biology. So I would rather use bone graft rather than using any kind of bone cement.
But Dr.
because of these
Raza,
problems.
that bone you are using, osteoporotic bone, is also osteoporotic. And you are adding another operation.
Sir, I think you don't know the definition of osteoporosis then. Because it is...
Well, I know. Whole world knows the definition of osteoporosis.
One minute, sir.
Do you think that...
1 minute, sir.
Hold on. Do you feel that osteoporotic bone has strength and osteogenic capacity? Strength and osteogenic capacity.
Do you feel that osteoporotic bones don't heal at all?
No, they heal.
They
But
heal.
do they have
That means-
strength and osteogenic capacity?
Once you say that osteoporotic bones heal, it means they have osteogenesis, genetic properties. So they will heal. So in all these situations, osteoporotic bones heal, right? So they have that potential to heal, one thing. The second is that here the trabeculae, and mind you, I have been studying the trabeculae for the last 20 years. So I know about the osteoporosis. 1 minute, let me answer that. See, what you are doing is that in the trabeculae are less. But whatever trabeculae are there in osteoporosis, the trabeculae are normal. They are not abnormal like you have in osteomalacia. Here you have less of trabeculae, but whatever trabeculae you have, they are thinned out and all. But they are normal trabeculae, normal bone. Here what we are doing is pulverizing everything, making them into a sort of a bone cement type of a bolus. And then you are packing it in. So once you're packing it in, you're increasing that. So this is normal bone which you are compressing and packing it. So it is not that they are spread out like that which are weak.
I think I'm Dr. Sanjeev Gaur from Bhopal. Since you have this debate of fixing it better and getting osteosynthesis, my question is slightly different angle. We all know that unstable trochanteric fracture in older patient does not have good outcome. Whichever method you use, whatever way you use it. So my question is, where you will consider a primary hemi or bipolar or total hip, in which cases, rather than bunging in these implants, which go haywire everywhere in, say, 80 plus unstable fractures.
Okay, let's ask Dr. Chakravarti. Let us ask all the penalty faculty members one by one. Short answer.
Yes.
Short answer. When?
Thank you, sir. If the patient's requirement is less, the bones are in a condition where they don't hold the osteosynthetic devices, whether it is intramedullary or extramedullary, one can go in for replacement.
Okay. Dr.
Number
Gupta.
one. Number
Hello,
two.
Dr. Gupta.
Number
You said,
two, if the requirement is very little, the patient is confined inside the house,
No, his question is,
then we do
elderly
a,
osteoporotic 4-part, when would you consider a hemorrhage? That's his question.
that's what say.
Am I right, doctor?
If the patient is restricted inside the house,
Okay.
requirement is less, one can get away with a hemiarthroplasty.
Okay. Dr.
If-
Gupta?
I fully agree with Dr. Chakravarti.
Okay. Dr. Kulkarni?
There is severe osteoporosis. If the fracture is very unstable and has got multiple pieces, the ideal treatment would be the replacement.
Dr.
Otherwise,
Raza?
if there is just the 4 pieces, you can.
Dr. Raza?
In my 20 years, I must have done an DHS for more than about 700 cases, and out of that, about 5 or 6 failed. And these were day 1 failures. So I accept that they were day 1 failures because I should have seen the sinks and decks, found out that if it was just 1 or 2, then I should have gone in for a primary first hemiarthroplasty with a bone cement rather than resorting to DHS. So these are the cases which fail. Severe combination, severe osteoporosis, they would fail. Day 1, it's not a question of the this thing. Quality of bone and amount of combination.
Sir, I feel those patients who cannot withstand the second surgery, severe trochanteric fractures, osteoporotic, they cannot stand the second surgery, all should be subjected to primary.
I think what's the current, I'll tell you. It's a 4-part fracture. The important part is lateral buttress of greater trochanter. We are talking about implant and fixation. There is important part is vascularity. In a 4-part fracture, your trochanteric vascularity comes from the lesser trochanter psoas and greater trochanter gluteus medius, right? And gluteus medius, lesser trochanter is an extrusion fracture because if you don't fix it, unites. But greater trochanter is extrusion avulsion fracture. So you get a 4-part fracture where your greater trochanter is avulsed. So 4-part osteoporotic avulsed greater trochanter and take a lateral X-ray. If it shows the fracture going to the subcapital or region, because we took the CT scans and we found that these fractures are in fact not intertrochanteric fractures, they are combination. In those cases, you are justified in doing, and there are 5 important reports today say that that probably is the best answer. So 75 plus, 4-part fracture, extending into the mid part of the neck in elderly people, today the world accepts that bipolar may be a good answer. Any question? Yes, doctor?
Yes. Sir, I am Dr. Ashwini Mathur from Jaipur. My question is to Dr. Gupta. Sir, in your PFN cases, did you ever have any complication of breakage of guide wire? And if yes, then how did you deal with it?
Leakage of?
No, Dr. Gupta, questions to Dr. Gupta. Dr. Gupta.
Yes, there was one patient where the guide wire broke. Yes, there was a patient of guide wire breakage. Though usually I am very, very careful while rimming it over the guide wire that I maintain the same axis in which the guide wire has been introduced. When the guide wire broke, I had no other option except to take it off, take it out.
Yes, doctor?
I had no experience of the
You know.
breakage of guide. Yes.
Thank you.
I think the problem comes, what your answer is correct. Your guide wire, which looks good, when you rim, sometime it comes out. So you have a tendency to pass it a little more. And when you are putting your rimming guide, the tip bends it. And with that bends it, then you get into trouble. I personally feel what should be done is when you pass that guide wire, the tip and nail should look the same. You should have no difficulty in putting your nail inside. If you feel while rimming you have a problem, there is a trouble. Also, many times when you do that, your guide wire keeps on coming out.
Yes.
You remember? And I think what you do is keep your nail tad distance about 10, but tip you put into subchondral bone and lock it. And when you rim, don't rim continuous. Out, in, and then. And use a cannulated device, because if you see there is a fear, then through your rimming device you put a wire so that it doesn't come out. This is a problem which is very common, doctor. And this small tip will help you to a great extent.
Very important, which Dr. Lord said.
I would just like to know.
Just rim it,
Yeah,
take out the rimmer.
right.
Again, rim it, take out the rimmer. So that the wire do not move along the rimmer inside.
Guide wire breaks for 2 or 3 reasons. Number 1, your guide wire is thin. Number 2, your guide wire is not in an axis, it deviates. It deviates from your desired place. And number 3, in all such situations, when you use a power reamer, that is the reason where your guide wire will break at the point where it takes turn. So beware, have a straight guide wires, don't use them again and again, throw them, after 3 or 4 cases have the new guide wires. Use a manual reamers, don't use a power reamer. And if at all it breaks, then you have many methods to take it out.
Are we using manual reamers for PFN routinely?
People use, but I personally feel power reamer with low speed. You see what happens is, when you do an operation, don't use this. Use this and use this, the sound. That's best way to do. Normally because you want to finish, I do operation in 20 minutes skin to skin. That's bad. That's bad. The feel and feel the difference. and what suggestions he gave were correct. Yes, doctor, behind you.
Thank you, sir.
Name your question and question to whom?
Greetings to all. I am Dr. Neeraj from Bhiwadi, Rajasthan. My question to Dr. Kulkarni, please.
Yeah, Dr. Kulkarni.
Sir, after DHS, if distal segment slides medially, is the culprit only lateral wall instability or early mobilization or anything else? And what should be done next?
When there is a medialization occurs.
Yes, sir.
No. You don't allow it to do medialization. You have to do proper reduction, put the guide wires properly, fix it, there will not be any medialization will occur. And then you have to reconstruct the lateral wall if there is lateral wall lubrication. And then there should not be any medialization occurs. Because medialization occurs only if there is a collapse occurs post-operatively. To prevent post-operative collapse, you have to do bone-to-bone contact, compress the fragments, all the fragments to be compressed intraoperatively, then there will be no post-operative collapse, no medialization.
Yes, sir.
Dr. Kulkarni,
Unfortunately,
many
after surgery,
Dr. Kulkarni, many times you see a fracture and it is medialized.
No,
You take an X-ray
Huh.
and you take an X-ray, you see that it is already medialized.
The medialized
Now,
only if there is a lateral cortex
correct.
breakage or if there is a transverse fracture.
Yeah.
In those cases, you have to bring it back, reduce it properly, pin it provisionally, and then use whether
That's
you
right.
use THS or whether you use nail, both are the same.
Sir,
Both are equally good results. But the intraoperative bone-to-bone contact, intraoperative compression, that's the key
Dr.
word.
Kulkarni, he wants to have some clarification. What is it, doctor?
Yes.
What do you want to know?
sir, if after all post-operative surgery, in post-operative time, if it slides medially, then what should be done next?
During post-operative it slides,
Post-operative
then what do you
slides
do?
sometimes.
Yes, Dr. Kulkarni? Yeah.
If there is a post-operative slide, you have to quantify how much sliding it is.
Yeah.
If it is more than 1/3, then you have to go back and do it again. If it is less, 1/3 or less, leave it alone, the fracture will heal.
Thank you.
See, the test is if patient has no pain and patient can actively flex an assisted SLR, assembly probably is subclinically stable. You are justified in waiting. If the patient says, I have pain, patient is not able to face. Clinical is very important, not X-ray. We keep on seeing the X-ray. You should see the clinically. If he is not able to do that, what Dr. Kulkarni says is right. Go back, because this assembly is not stable. You have unstable somewhere, so correct the stability. Next, please.
Thank you, sir.
Can I answer that, sir?
Yes, you want to make a comment?
On that only. See, it is for fracture fixation anywhere in the body. The basic concept for a biomechanics is to have a stable reduction. The key word is stable reduction. So anatomical reduction in all trochanteric fractures is exceedingly important. So don't say that I have fixed it so that it will collapse. Have try for an anatomical reduction, whether you do a DHS or whether you do intermediate device. Anatomical reduction is the key word. You can have your own preferences, but that is the key word, and that is the only thing I want to say. Once you have done that, then the amount of collapse and all will be there. But once you start having a collapse, then with a DHS, the collapse will occur, it will go on occurring till it settles down. And sometimes, if for a 70 mm or 75 mm screw, if you used a large barrel, then it will be dangling, and that will give rise to a non-union. And because the collapses occur to that area, and it won't go further. And then it won't settle down, and then it will go in for a non-union. So for 75 mm and less of screws, you have to use a short barrel.
I think our time is, how many are more? Our time is getting over. Yes, 3 last? Okay, 3 last, all right.
My name is Dr.
Because we have come for
Goswami.
you here.
I'm from Delhi, sir. My question is for Dr. Raza. Sir, the role of derotation screw in a typical IT fracture. So we know that DHS works in the principle of controlled, collapse of the proximal fragment over the distal fragment. If you are using a derotation screw in all stable IT fractures, are we not inhibiting the same principle and making a DHS not having that dynamic collapse after the surgery? I understand static compression is what we get on the OT table while we're doing the surgery, but dynamic compression itself will get inhibited once we're using the derotation screw for a stable IT fracture.
You're absolutely correct. The key thing over here is whenever you use 2 screws, whether it is with the use of an intermediate device, you're using 2 screws, or whether you use another screw, which I call a butter screw, it prevents a collapse proximally. It adds to the substance of that, increases the amount of material inside the head of the body, and it provides for this thing to not to collapse. Here you have to be absolutely parallel. That proximal screw cannot be in any other direction, but once you have it parallel, then both the screws would collapse together.
I
That is
understand
what
that very
happens.
well.
So
Sir, I
it settles down.
Sir, I understand that very well. With the PFN, it's very easy to put 2 screws because you have a jig that helps you do that. For a DHS, while you've already put in the Richard screw, that loss of parallelism inevitably happens.
No, when
Because-
you are putting in your guide wires, that's the time when your parallelism can come in both in the AP and the lateral view. So except only the parallel guide wires. So you already have a guide wire in place. As it is, when you are reaming, you have to have an additional guide wire just to avoid the spinning of the head.
Sir, that
So
we normally
that's
do
the time.
for a basic cervical neck fracture.
Doctor, thing is, it depends on the configuration. If you have 2-part fracture, which is well reduced, as Dr. Raza says, both in epilateral, you don't need. When do you need it? If a fracture line is somewhere near base basal, and you're going up, and you have this movement, this.
The translation. So
in
what
the
we get for
sagittal-
basic cervical neck fracture neck
This
femur.
movement in sagittal plane. So this fixation is good. All you need, while this is acting, to prevent this.
It should rotate.
That's where the anti-rotation screw. So your fracture line goes from right below, and if your lesser trochanter is separated, that means your medial buttress is not there. That's the right time you need to prevent the rotation of the proximal fragment. So reduction and anti-rotation screw is to further accentuate your osteosynthesis, which you have got by primary.
So that was
That's-
exactly my question because
Uh,
Raja said
my-
I've been using it in
my-
all cases.
In my view, the use of this extra screw is for 2 reasons.
Okay, sir.
One is in all osteoporotic fractures, where it improves, makes it, in Hindi, say, ठोस हो जाता है और, because you have once you put an extra screw, the bone also is compressed all around, with that, so it increases the tamponade inside the neck and the head of the femur. That is one thing. The second is that where you have a lateral wall, which is shattered, and you use a large washer along with it, it helps to buttress that in place. So this is why I use that extra screw. The precaution is it has to be absolutely parallel to this thing.
Right, thank you.
No, Dr. Raza, the problem is, in sagittal plane, there is a fracture in the lateral wall. In sagittal plane, not in frontal plane.
Extra
So actually your
anteroposterior screw.
goes through the
Extra
fracture.
anteroposterior screw. Extra anteroposterior screw is what
That's
we
right,
use.
that's right. Which is the last question?
Or an extension.
Yeah.
Patients, an extension will be required.
Yeah, time ho gaya. Last question. I think the last
Sir,
question.
I am Dr. Pavan from Warangal Kakatiya Medical College, final year student, sir. I am Dr. Pavan from Warangal Kakatiya Medical College, final year student, sir. I have one doubt from Gautam, sir. Sir, you have mentioned one case that you have treated with rush nail, one X-ray. You have shown that one X-ray have treated by rush nails. Why you have selected rush nail? Why not the ender snails, multiple ender snails?
No, one thing is
and
there.
one more question, sir.
Yeah.
And what is your experiences with multiple ender snails? Because in our institute we have treated out of 7 cases with multiple ender snails in more osteoporotic patients, and 2 out of 7 we got 2 excellent results, sir.
Probably you have taken the paper in a wrong way. The rush nail was coated with an antibiotic coated cement. It is not a simple rush nail. You can put in an infected non-union, you can put in only one implant. You can ask me the question why I chose a rush nail.
Yes.
Because of the simple reason that where if you coat a K-nail, diameter to diameter, it is weaker than a rush nail, number one. Number two, with a rush nail where the diameter of the nail is less, the amount of cement you add is more. So keeping in view those things, I used a rush nail. And second thing, the hook is out. So it will be easier to take it out once you feel like.
Doctor, thing was, you have treated it primarily with ender nail.
Yes, sir.
Okay? He has used it for an infected non-union as a spacer, with an idea that when infection comes out, he will take it out and do a definitive. But to his surprise, the fracture united alongside. When he told the patient, let me take the cement out, she said, no, thank you. Now, many times our patients are good, but understand that, explain to the patient that it has a problem, don't keep it long time. Last question, doctor.
Thank you.
Now, one comment on this.
Yeah.
See, you should never use a rush nail for cementing outside, for if you want to use an antibiotic coated nail. You must use a K nail, because the K nail has got a clover leaf, the cement goes inside and outside, it gets locked. If you use rush nail or similar type of nail, then while putting or even while taking out, the nail comes out and the cement remains inside. It is good that the patient did not ask him to, because if you had tried to nail,
In that condition, you put in a reamer, and all the bones cement.
Okay, I think you can discuss during the lunchtime. The last question.
Thank you for allowing me this last question. I agree, I am Dr. Jishnu from Assam, Dibrugarh, and I agree with whatever Dr. Raja said, but I have two doubts on what Dr. Kulkarni said and Dr. Gupta also. So may I be allowed just two questions, each for Dr. Kulkarni and one for Gupta? Yes. Sir, you said that the nail, it's about biomechanics, the nail, when put in a trochanteric fracture, supports both the medial wall as well as the lateral wall. I fail to understand the lateral wall, how it supports the lateral wall. Because we are having cases where those fractures, after they are well aligned, even when they are left from the fracture table, traction is released, they go into varus pro capitum malreduction, and the lateral wall distracts.
Doctor,
Yeah.
the nail buttresses the proximal part of the fracture. Once it buttresses the proximal part from the nail, it protects the lateral wall. So the lateral wall is protected.
I think the
And-
question is Dr. Kulkarni, yes.
yeah. See, when there is both medial wall and the lateral wall have been broken out, you must reconstruct the lateral wall.
Yeah.
Reconstruct it with a tension band wire. You can put anterior-posterior screws or any other purposes. You must reconstruct the lateral wall. Even if you don't, even if you put a nail
with
which
encircles
it buttresses theoretically, it is better to reconstruct the lateral wall. Otherwise, failure, if the lateral wall is not reconstructed, the failure rate is very high, even if you have nailed it. And the medial wall, if the medial wall is also shattered, then you must bone graft it, primarily. You
That is
must
the
reconstruct the lateral wall, but if the medial wall is very shattered and there is going to be a void, if the void is there, then there is again a chance of failure.
Yes, you
There are
clearly-
three places in the
think,
body, the proximal humerus, proximal femur, and distal humerus, where if there a medial wall is shattered and there is a medial void, all these three places should be bone grafted or strut grafted to give a support to the medial wall.
That's
So
good, right?
you must try to reconstruct the medial wall and the lateral wall if they are shattered. If there is just a small crack, then the nail itself will act as a buttress to the medial and the lateral wall.
It's a
That's
tensile
all?
side.
Yes, doctor?
It was the tensile side. It will always distract on loading.
I
If
think,
you do
Doctor,
not-
you can discuss with Dr. Kulkarni and others during the
Once you
lunchtime.
open up a fracture for bone grafting, a major part of the advantages of intermediate fixation
I
goes
think
away.
our Dr. Raza, but understand one word, very important word, damage control orthopedics. That's a key today, right? You use anything, don't keep on adding things which will damage the existing situation, because in addition to the bone and your implant, there is important thing, blood supply. And any additional thing you do, you are disturbing blood supply, which is going to take a time to restore. Don't forget that. Okay? All right, we had a good discussion. Thank you very much, and I would like to thank the panelists for their good and established opinion. It was good discussion, and I think we should be very open about it. And Dr. Gupta, good to see you. Okay, second. Good to see you. You are so good.
And I request the panelists to give a write-up within 1 week on the specific subject on which they are speaking, so that we can compile them as a document. Friends, without wasting a time, I think we start with the first presentation with my co-chair, Mr. Venu from UK, and Dr. Vijay Raghavan from Chennai. Well, we have divided this program in terms of curriculum, type of competency. May I request the people not to talk in the hall loudly. Please don't talk in the hall loudly. Dr. Raza sir, may I request you to please. So the first two talks are on curriculum. So let's listen to Mr. Venu about ideal orthopedic curriculum for modern orthopedic training in 2013. Venu, please.
Thank you very much, Dr. Jain. It is my absolute pleasure standing in front of the greatest educators in Indian orthopedics who have produced so many of my colleagues back home in UK. But however, the time has moved on. The kind of training I received and my colleagues received is perhaps different to the training we are delivering to our trainees in England at present. So just to go back to basics, we're talking about the ideal orthopedic curriculum for modern orthopedic training. The curriculum should provide the total learning experience provided by any training scheme that includes not just the content, the methods of delivery, and the assessment throughout that course, so that you are certain that the content through your methods of delivery resulted in good training. So there is a definite need for curriculum. In the past, the curriculum was implied, but we definitely need a structural curriculum, because it definitely raises the minimal acceptable standards, which is very important in medical training. It also formalizes the training pathway. The trainee would know from day one what he is expected to achieve by the end of whatever years of training process. It improves better training environment for the trainee and the trainers. And finally, this is what we want, an improvement in our patient care. If you look at current status in India, the competitive postgraduate exam or sometimes donation results in achieving a placement in this training, but there was no standardized national curriculum in orthopedics. It is predominantly knowledge or apprentice based. They gain medical knowledge and surgical skills, and they achieve postgrad qualification. But the current training scheme does not have any formalized leadership, clinical governance, or outcome measures examples in the curriculum. And what they do, they go to centers of excellence in India, and India is very fortunate to have so many top centers of orthopedic training and top excellent surgeons in orthopedics as well, and they also come to overseas for experience. Perhaps there is no proper regulation here. It is, I think, quite under-regulated. But if I give you the training we provide in the UK, we have general medical councils, royal colleges, then specialist societies, perhaps a bit too much regulated, but it's always under constant reforms. Some of you who were trained in the UK, at that time we had this particular training scheme called Coleman training. Some of you may be aware. And since then, we had so many other new reforms and so on. But the whole purpose of these reforms, we noted, was to improve the patient outcome. Our recent health secretary mentioned that our investment in education training is an investment in patient safety and improving healthcare outcomes. It's really nice to hear these kind of comments from a minister. But the purpose is to move from subjective, knowledge-based, or single center training to objective, competence-based, perhaps multi-center training. There are so many papers, so many studies done looking at how to make sure that the training has been properly acquired by the trainee, and there is no doubt that it is based on competence.
So this is a common Western training program where the trainer's profile from his knowledge and the kind of procedures he does, particularly in surgery, forms a learning agreement with the trainee based on the requirement of the trainee, and then that training process is assessed, acquire the evidence of the training, with required coaching, and finally, when the training is finished, the trainee can be expected to become a safe and competent surgeon. In UK, we got orthopedic trainee appointed through interview system. Then they receive general orthopedic training. They pass FRC SORT examination, generally 4 years after specialist training. Then they get into specialist orthopedic fellowship training for about 2 years, or nowadays it is more than 2 years. And then they receive certificate of completion of training, which means that the person is capable of acting as a consultant and looking after the patient under his care. But the modern curriculum we have, actually it covers the whole spectrum of this area. So who sets the orthopedic curriculum in UK? As we discussed, it has content, delivery and assessment. So General Medical Council, along with the Royal Colleges, they set the whole curriculum, very detailed curriculum. And the regional deaneries, with the program directors and the School of Surgery, they make sure that the curriculum is relevant and they implement, and the hospitals, the educational leads, and finally the consultants make sure that the curriculum is followed to meet the needs of the trainee. So the content is decided by the top group, whereas the delivery is by all these bodies, but it's important that that includes the assessment to make sure that the trainee progresses through the list of competencies. So this is again, the content includes applied clinical knowledge, applied clinical skills, and more importantly, the professional behavior, which is part of curriculum in most Western countries. So if you look at the stages of training in orthopedics in the UK, they go through early years, generally first 2 years, they learn about routine trauma, ethics, research methodology and audit, and you can see these important areas are embedded right from the beginning of the training. Then the middle years, where they do a bit more of elective orthopedics and they do advanced trauma. And the later years, usually during the fellowship period, they learn even more advanced trauma and they learn subspecialty elective orthopedics, whether it is purely on hips or knees, revisions, anything. So this is quite a busy slide, but it just shows what a trainee is expected to go through this training process throughout the period of curriculum. So in the content we discussed about clinical knowledge, clinical skills and professional skills, and I will show you some examples. This is a very busy slide showing the applied clinical knowledge within the curriculum, and you can see there is a lot of emphasis on basic science of all the conditions we commonly come across, and the trauma as well. But this again, it is very clearly spelled out. The applied clinical knowledge should include all these topics. And then they acquire clinical skills, whether it is simple clinical examination skills or decision making regarding treatment, then operative skills. It includes research and audit, which are part of our clinical skill acquisition. And then these are the spectrum of clinical skills they are expected to acquire during the curriculum process. But more recently, there has been huge emphasis on the professional leadership skills. Just again, there has to be a kind of objective evidence that the trainee has acquired these skills. So ethics plays a major role. Then again, it is not a very simple heading of showing ethics. It has so many different components. The trainee has to show that it has progressed through all those components. And then we deliver that orthopedic curriculum which is done by these bodies. How is the delivery done? Of course, for the knowledge, we have weekly local teaching programs, weekly regional teaching programs within the region, which includes MSc Orthopedics, and then for trainees who are reaching year 4, They receive specific FRCs, trauma and orthopedic examination training. We have journal clubs weekly and clinical conferences, and there are certain mandatory courses. Within first 2 years, they have to do ATLS and AO basic and then AO advanced courses and so on. These are all mandatory, otherwise the trainee can't progress to next year. And there is huge emphasis on basic sciences, as I mentioned, and research methodology. All trainees should have acquired knowledge and skills in these areas. And then assessment is the most important component, because there has to be an evidence that the trainee has progressed through this training process. And these are the bodies that make sure that that assessment is done properly. So we have annual review of the trainee progression, ARCP, where we